Bismillahirrahmanirrahim. Welcome everyone. So in this video we'll talk about hypovolemic hyponatremia. Again, this is a quiz from the last video. So if you haven't seen it before, you can pause the video and then answer the question, and then we'll go over the answer. Now, all these options are associated with either euvolemia or hypervolemia, and only primary adrenal insufficiency is associated with hypovolemia, as we will discuss in more details in this video. So in normal uncomplicated pregnancy, there's usually increased intravascular volume, as you know, and there might be dilutional, mild dilution and hyponatremia as a result, and it's usually asymptomatic. In nephrotic syndrome, because they have hypoalbuminemia, they might also have some ascites and some water retention, and they might be hypervolemic as well. In SIDH, these patients are usually euvolemic, but they can be also mildly hypervolemic. So none of this is really associated with low volume status except for primary adrenal insufficiency, and today we're going to know why. Okay, so compared to hypervolemia in the last video, for hypovolemia, you will be looking in history into something like GI losses, like vomiting, diarrhea, bowel obstruction, if there's any drains and how much these drains are draining, if there's any fistulas and how much is discharged from the fistulas, to get a sense about the GI losses, which could be contributing to the hypovolemia. Also, skin losses, a little bit less common. GI losses are much more common. So excessive burns, excessive sweating can also sometimes be contributing to hypovolemic hyponatremia. And then also relatively common is renal losses. So you want to take a history of how the patient is taking diuretics or not, especially hydrochlorothiazide, which is actually associated with hyponatremia more than diuretics, and we will discuss that further. And then primary adrenal insufficiency, also we'll talk about this, also usually can be associated with hypovolemia due to hypocorticism. Renal salt wasting, there are specific kidney diseases that are more commonly associated with salt wasting, including reflex nephropathy, acute interstitial nephritis, and chronic interstitial nephritis, which has like really many causes, including drugs and infections and toxins. Also obstructive uropathy, medullary cystic disease, or a patient who was in the recovery phase of acute tubular necrosis from any cause. This patient also can have polyuria and loss of volume and electrolytes, and subsequently hypovolemia. Patient with glycosuria also might have some water and volume loss from the kidneys, and the same for ketonuria. And then there is the other less common entity, which is somehow debatable, is the cerebral salt wasting, or we'll talk about this as well. So these are the things you look at from history. In the cerebral salt wasting, basically there will be like history of intracranial process like hemorrhage, and the patient might be in the critical care unit or neurocritical care unit. So, and then from physical exam, you look at some of the findings which might be associated with hypovolemia, although these are not very specific or sensitive, as we showed or discussed in the last video and in the review that I showed you last time. But you're still going to look into physical finding like dry mucous membranes, sunken eyes, decreased skin turgor, and you will check orthostatics to see if the patient is having orthostatic hypotension or tachycardia. And then we talked about how point of care ultrasound recently can be really useful. So you might look into the IVC, inferior vena cava, to look into the diameter. And usually with hypovolemia, expect it to be small, less than 2 centimeters generally, and it usually collapses more than 50% during inspiration. And also if the patient is not having left ventricular heart failure or myopathy, then as a compensation, the heart will be hypercontractile. So you might see hyperdynamic left ventricular function on bedside ultrasound as well. And then in the labs, so ADH, again, we don't usually check the serum ADH, but ADH usually is increased appropriately in these patients because hypovolemia is a non-stimulus to ADH. We'll discuss that further in, I think it's going to be the next video. And then the kidney will try to retain water and salt to compensate for the hypovolemia, so the urine osmolality will be high. It's usually more than 400, and that can also be reflected in the urine specific gravity, and it will be increased as well if you're still waiting for the urine osmolality to be done. And then there will be like maybe some AKI in some patients, especially BUN. Blood urine nitrogen might be more increased than creatinine, and the ratio might be more than 20 or 25 or 30. And then uric acid also might be normal, but it might also be high normal or even high, partly because of hemoconcentration. And then if the patient is not having chronic left ventricular dysfunction, the BMB might be low. Of course, as we talked about before, there's no gold standard test for volume status assessment, but usually with hypovolemia, when you give them fluid, things get better. So that could be an indication that it's a case, it's a cause of hyponatremia. Now, of course, you really want to do a good assessment before you give fluids, because if the patient is having hypervolemia, then giving fluids will make things worse. And then, of course, the urine sodium can be variable. So if the patient is hypovolemic and they're taking thiazide diuretics or even loop diuretics, the urine sodium might be low. So it might be high because it's being secreted in the urine. But generally, if the patient is not taking diuretics and there is no renal salt wasting syndrome or cerebral salt wasting syndrome, because these could cause also increase in the urine sodium. If there is no suspicion for that, then most of the other causes like GI losses, in this patient the urine sodium will be low, usually less than 20, and that could be helpful in the workup. Okay, so let's discuss the diuretic-induced hyponatremia. It's a relatively common cause of hyponatremia. This is really one of the first thing that you should look at. Ask about the drug history and whether the patient has been taking diuretics or not. Specifically thiazides, because thiazides are up to 10 times more common to cause hyponatremia compared to loop diuretics, and we'll discuss that in a bit. And then it can happen anytime, mostly after 2 weeks of the use of the thiazides in patients with particular risk factors, as we will see. But it really can happen months or even sometimes after a year or two, has been reported in some cases. So just be mindful, look into the drug history more carefully, and ask about thiazides. Risk factors, this can happen more commonly in elderly, especially if they're females, patient with low BMI, if they have some kidney dysfunction, some kidney injury from any underlying cause, or if they're starting to get progressive kidney dysfunction, and specifically if they have like hypokalemia or hypomagnesemia, that can also make the hyponatremia worse. And then the treatment, of course, is you stop the drug and consider other blood pressure medications for the patient. And then if the patient is hypovolemic, you need to replace the volume with isotonic fluid like normal saline. So what happens with loop diuretics? So we know that the thiazide diuretic, they work in the cortex, in the sodium chloride symporter. They block this symporter, and that will lead to loss of sodium and chloride, in the urine. Now, when it comes to the loop diuretics, it also blocks the sodium potassium 2-chloride co-transporter, and what that will lead to decrease in the osmolality in the medulla. So the medullary osmolality will be much less after the use of loop diuretics. This doesn't happen with thiazide diuretics because thiazide works mostly in the cortex, but the loop diuretics, because they act on the ascending lobe of Henle, which is present in the medulla, then it can affect the osmolality in the medulla. So what happens here is, well, the ADH basically opens the water channels, or the aquaporins, as some people like to call it, and this aquaporins will allow the water to move across the osmolality gradient. So water will basically move from the tubule and be reabsorbed into the medulla when the concentration is high. The higher the concentration, the more movement of water will happen. But when you had a loop diuretic, as you can see here, the medullary osmolality is less, so there will be less water movement. So less water will move across the osmolality gradient because of the decrease of the osmolality gradient, because of the loss of salt, mainly sodium, potassium, and chloride in the tubules, rather than being reabsorbed into the medulla. So less water will be reabsorbed, so the dilutional effect will be less. This mechanism is intact with thiazide, so there will be more dilution, more water will be reabsorbed because the osmolality in the medulla is intact, and that will lead to more dilution and more hyponatremia. And that's theoretically why loop diuretics affect the sodium less than thiazide diuretics. So if you have a patient on both, for example, they are really on advanced kidney disease, edematous, having ascites, and they're having issue with sodium, you might consider stopping the thiazide rather than the loop diuretics. Also, patient with progressive kidney dysfunction, thiazide diuretics are less likely to work anyways. So in these patients, especially if they start to have more edema, you might need to consider shifting them from thiazide to the loop diuretics, and that also will work in your side that the sodium will be less affected by the loop diuretics. Okay, good. Now, how about hyponatremia with adrenal insufficiency? As you remember, there's two types, or three, but the most common two are primary and secondary adrenal insufficiency. So in primary adrenal insufficiency, there is a disease of the adrenal gland itself, like autoimmune adrenalitis, like in Addison disease, and this will lead to destruction of the cells responsible for secretion of both cortisol and aldosterone. So in primary adrenal insufficiency, there's usually hypovolemia, and that's mostly because of the decrease of the aldosterone. And we know the main function, one of the main functions of aldosterone is to increase the absorption of sodium, and increase the excretion of potassium. So where there is destruction of the adrenal gland, a primary adrenal insufficiency, there is decrease in the excretion of aldosterone. That will lead to loss of salt in the urine. So if you measure the urine sodium in this patient, it should ideally be high, and this will lead to loss of salt, loss of water, and decrease in the volume. So most of the patient will be hypovolemic. That's why they most of the time they look a little bit sicker. This could also explain the relatively low blood pressure, the small heart, and some of the clinical features known to be associated with primary adrenal insufficiency. So the renin, angiotensin, aldosterone system, it will be really affected because the system cannot really work well in the adrenal gland because of the primary adrenal gland disease. Now compare this to the secondary adrenal insufficiency, when there is a problem with the hypothalamus pituitary adrenal axis. So the ACTH, which is the hormone secreted by the anterior pituitary, and it's a regulatory hormone that will go to the adrenal gland, but this hormone actually mostly affects cortisol, and it doesn't affect the aldosterone as much compared to the renin, angiotensin, aldosterone system. So the cortisol will be affected, but the aldosterone mostly will not be affected. So there's no much of salt or sodium loss compared to the primary adrenal insufficiency. The cortisol will be affected though, right, because of the decrease in the ACH production because of the disease, for example, in the anterior pituitary. So low cortisol would be associated with increase in the ADH. We'll talk about that in more details in the next video. And this will lead to SID, or syndrome of inappropriate ADH or AD secretion, like pictures. And that's why most of the experts, they recommend ruling out secondary adrenal insufficiency in any patient with clinical features similar to SIADH. So they usually say you almost always have to rule out secondary adrenal insufficiency by getting the morning cortisol or doing the corticotropin test, and also rule out hypothyroidism by checking the TSH in any patient suspected to have SIAD or SIADH. We'll talk about that in the next video. But again, aldosterone is not affected, so the volume status is most of the time is actually euvolemic or even mildly hypervolemic, like in some patient with SIAD. So this is really a main difference. So the clinical picture sometimes can tell you whether the patient is having primary or secondary adrenal insufficiency, and that's mostly why. It's more common than hyperkalemia. We talked about primary adrenal insufficiency affecting the aldosterone. So when there is decrease in the aldosterone, there is increase in the potassium retention. But hyperkalemia is not present in all cases, and hyponatremia is more common than hyperkalemia in these patients. And sometimes the hyponatremia can be really the only prominent feature of this syndrome. So when you have a patient with hyponatremia, chronic hyponatremia, you're not really sure what's going on. Don't forget to check for adrenal insufficiency in these patients. So a relatively less common cause of hyponatremia or hypovolemic hyponatremia is renal salt wasting or salt losing enteropathies. So probably this syndrome or this entity was suggested in a paper by Thorne et al. In 1944, where they had like case report of two young patients with azotemia, AKI, kidney problem patient who thought to have adrenal insufficiency, but there was no response to adrenal cortical hormone. So the patient these two patients, they responded though to salt and fluid alone. It was thought that this patient with kidney disease probably has one of the salt losing nephropathies. So possible association include patient with reflux or obstructive nephropathy due to any cause, patient with acute interstitial nephritis or chronic interstitial nephritis. There are many causes for these as well, including medications, vascular disease, also patients with medullary cystic disease of the kidneys, after recovery of any cause of ATN. So a patient who are recovering from ATN, you need to monitor them closely for loss of electrolytes and sodium and volume, during the recovery phase. So you have to keep an eye on their volume status and ins and out, input and output daily. Also, some drugs like analgesic or chemotherapeutic agents might also be associated with renal salt wasting, and some genetic causes, which is much less common and rare, including Gentleman disease and Bartter disease. And these two genetic defects, they look like Gentleman looks like thiazide, chronic use of thiazide, and Bartter looks like patient who was taking loop diuretics chronically, and both of them might be associated with hypokalemia, hypomagnesemia, and metabolic alkalosis. So just to compare the renal salt wasting to SIAD, which is more common, so there's some similarity between the two. As you can imagine, there's increased urine osmolality in both, here because of the loss of salt, and here because of increases of the ADH. Uric acid also might be low. In SIDH, as you will see in the next video, there is some loss of uric acid as a compensatory mechanism. And in renal salt wasting, it's not really quite obvious why the patient is having low uric acid. But with SID, there's also increase in both. Actually, there's increase in the excretion of urate or increased Phe rate, and that could partly explain the decrease in uric acid in renal salt wasting. And regarding the volume status, as you can imagine, in renal salt wasting, because of the loss of salt and volume, patient usually hypovolemic, and SIDH is patients are usually euvolemic or mildly hypervolemic. Both of these conditions are associated with increase in the urine sodium, but it's usually much more in renal salt wasting, as you can imagine, because of the continuous loss of salt in the urine in these conditions. And then when the hyponatremia improve, if for example patient with SIDH, if they have if you want to identify the cause and you treat it, the Phe rate improves. As the execution, loss of uric acid in the urine improves, but this usually doesn't happen with renal salt wasting, and this is something you might consider to differentiate between the two if you're not too sure. But again, usually with a good assessment of volume status, you might be able to differentiate the two conditions from each other. Okay, so the last thing we're going to talk about is cerebral salt wasting. It's really rare. You might not see it. It's actually debatable whether it exists or not, to be honest. Most of the possible associations are found in the neuro ICU. So a patient really sick with some head injuries, serious head injuries, intracerebral bleeds, subarachnoid hemorrhage, severe meningitis, encephalitis, brain tumors, or after neurosurgery. And these patients, because of all these insults, they might have increased BMB and severe natriuresis, and that's partly why they're losing salt in the urine. So to compare the two, as you know, SID or SIDH can be due to many causes. Some of them are in the brain or the CNS. So sometimes you might need to know how to differentiate the two. So in terms of volume status, cerebral salt wasting is usually patients are usually hypovolemic because of the wasting of salt, right? So you need to check blood vital signs, blood pressure, BUN, and hematocrit might help you to assess that. And patient with SIDH, as you mentioned, usually euvolemic or even a little bit hypervolemic. Urine sodium will be increasing both, but it's much more higher in cerebral salt wasting because of the loss of salt there. Uric acid is also expected to be in the lower side in both, but it's more commonly low with SIDH. I will talk about that in the next video, as we said. Urine volume might be increased in cerebral salt wasting because of the loss of salt and water. It might not be the case with SID, so it might be normal. Urine output might be normal or low. And then, as we said, these two patients might be sick. SIDH, most of them are not really sick, except if they're having SIDH from these severe conditions. So in these situations, when the patient is sick, they're having a lot of neurological issues, and the sodium is low, you might need to start with hypertonic saline to elevate the serum sodium a little bit quicker to prevent complications, like we talked in the first video. So in both situations, you might need to give hypertonic saline. So the treatment is similar in that perspective, but again, remember that the volume status is different. Patient with cerebral salt wasting might more likely to develop a hemodynamic instability, so you might need to consider resuscitation with saline and isotonic fluid in this patient compared to SIDH when they usually not having these issues. Alright, so finally we get to the quiz, so take a look at it, and with the next video is going to start with talking about the quiz first, and then we'll talk most likely about SIDH. See you there. Thank you.